everyone. Warm welcome. It's pretty warm outside as well to NCAR. My name is Ajay Mahal. I'm a professor at the University of Melbourne at the Nossal Institute for Global Health, along with my colleagues Sumit Kane and Barbara McPeak. But I'm also a professor at NCAR, along with both of them. So welcome to you all. The occasion, of course, is the final workshop of a Bill and Melinda Gates funded workshop on a project on health. Well, what exactly is it? Let me remind myself. Okay, it's a 5-year project on looking at people's health-seeking behavior in 4 Indian states, hence the 4IS project. We have 3 partners. There is NCAR, there is the Nossal Institute, and there is also the Population Council office in Delhi. So 3 partners. It's a 5-year project, and really it's felt much longer at some point, I suppose. But finally, we have come to an end, and that's, I think, of course, this is not the final piece of work that you will see. We'll see a whole range of papers that will follow from this project, and that will not be discussed here, but certainly that's something that we expect in the weeks and months to come. Thank you for coming. I think I well appreciate that it's not easy to come in the afternoon, but I also recognize that by coming here, you're sort of showing an interest that health is an important sector for the Indian economy, but also that you care about the well-being of Indians and their health and educational outcomes. So thank you for coming. We hope that we make it worthwhile for you. Just to get started with the plan is roughly as follows. We'll start shortly after I finish with a welcoming note by Dr. Anil Sharma from NCAR. We will then follow with a series of presentations by the project team, that's myself, followed by Prabir Ghosh, Barbara McPeak, and Sumit Kane. And then we'll be followed by 2 very thoughtful and, I guess, long-standing observers and astute researchers as well of the Indian health sector. There's Professor Rama Baru from JNU, Jawaharlal Nehru University, who, of course, doesn't need an introduction. She's been there for a long time. She's done lots of work in this area. And also Dr. Sajjan Singh Yadav, who was a former director of the National Health Mission, Rural Health Mission, and has participated in a number of leading roles in the health sector as part of the Indian government, I should say state governments. But I think the capacity that he's in here today is actually more interesting for me. He's currently at the Ministry of Finance, and that's really fantastic because we who work in the health sector don't engage with ministries of finance too much. So for us, it's a fantastic opportunity to actually, the fact that he's here. So thank you, Sajjan, for coming over. And then following the presentation by the discussants, that's Dr. Rama Baru and Dr. Sajjan Singh Yadav, we will have a question and answer session. And we're hoping to finish exactly at 4:30, because then what awaits us is a fantastic tea. And we certainly can't miss that, can we? So with those words, welcome again. Thank you for coming. And let me now invite Dr. Anil Sharma to give his welcoming remarks and also to release the first report produced as part of this work. Anil, over to you.
Thank you, Ajay. Good afternoon, ladies and gentlemen. On behalf of NCR Director General and NCAR staff, I would like to welcome you all to the dissemination event of a collaborative study about which Ajay has already introduced you, health-seeking pathways in 4 Indian states. It's a collaborative work between NCAR, the Nossal Institute at University of Melbourne, and Population Council. So thank you all for being here. And in particular, of course, Ajay is both a faculty at University of Melbourne and NCAR, but I would like to welcome him, Professor Barbara McPeak, and Dr. Sumit Kane, all 3 from Nossal Institute, University of Melbourne, and all 3 are visiting faculty at NCAR. And of course, the 2 discussants, Dr. Rama Baru, professor at the Jawaharlal Nehru University, and Dr. Sajjan Singh Yadav, IAS, Government of India. The media, of course, both print and electronic, and all our guests from outside NCAR. As Ajay briefly mentioned, this study actually was started in 2017 if I recall correctly, there was a pandemic in between. I think, the team carried out telephonic surveys in the meanwhile because they could not really carry out the field work. It's an important piece of work. But I think, before requesting Ajay to take over the proceedings, I would like to mention and I think, clarify that this study is not really talking about everything related to health. There are 3 specific conditions, which are really covered in the study, and how, the households are able to access services. And I think, what is happening to the financial protection part of, the expenditure. So with those details, I'll leave the floor to Ajay and his team to take over and, continue with the proceedings. Thank you very much again for being at NCAR. Thank you. Please join us.
So what I'll do, I'll start with a little bit of a background to the study, and then let Prabir Ghosh take over with describing the survey methodology and the data collection exercise, followed by Barbara McPeak, who will talk about the findings from the quantitative survey part of the work, and then Sumit will conclude with a discussion of the findings from the qualitative research as conducted as part of the study. Once this is done, we'll have the discussants over to comment on the findings that we'll talk about. So this study, as I think Anil mentioned, started sometime around 2017. I recall actually it's starting in 2018, but memory sort of is just failing me now because it's been a long time. So there are 3 partners that we discussed: the Nossal Institute, which is based in the University of Melbourne, the National Council of Applied Economic Research, where we are, and the Population Council Delhi office. The funding was provided, as I said earlier, by the Bill and Melinda Gates Foundation, again, Delhi office. So as you can see, there will be 5 parts of this presentation. First will be an introduction to the background of the work and some key research questions, which I'll talk about, followed by the study design discussion by Prabir Ghosh, then findings from the household survey by Barbara, Sumit on the qualitative inquiry, and then conclusion remarks, at least for this part of the presentation. And the way, at some level, it's sort of hard to discuss exactly what we did without giving you some sense of where we started out from. And what I thought was, I'll start out with 2 sort of stylized facts which guided the movement towards the research question that we try to answer in this particular study. And the first thing to note is, this is not, again, as Anil mentioned, this is not a study of the entire Indian health sector. It's a select set of questions driven by what we felt was certain interesting characteristics of the Indian healthcare system. So the first sort of stylized fact is that India, of course, has achieved tremendous improvements in child and infant mortality outcomes over the last half century or so. That's, I think, basically all expert observers will agree. That's something that's has been one of the remarkable features. And India is not unique. There is Bangladesh and Sri Lanka, and so on. All of them have made tremendous improvements in these outcomes over the last half century or so. But there is a flip side to this. The flip side, of course, is that once you actually start living longer, then combined with changes in the fertility rate, you end up with an aging population. And that's what we're seeing in India, graying of India's population. As I get part of the same group, I sort of feel much more affinity towards the elderly, and so certainly that's certainly the case. But of course, older people get all sorts of non-communicable chronic conditions. So what we are seeing is an emerging sort of, if you like, disease burden from chronic non-communicable diseases, partly as a consequence of our successes early on. Is that necessarily a problem? Well, at some level, if you go to Europe or Japan, nobody really, I mean, people are concerned about these conditions, but yes, ultimately, success in public health might very well translate into higher burden of NCDs. So in some sense, what I'm saying is, by itself, that need not be a problem for any society, because it's going to be common to everybody. So where is the problem coming from as we see it? What we see is essentially the fact that NCDs are occurring at much younger ages, and one good indicator of that is premature mortality from NCDs. This is the share of all deaths in the age group 40 to 70 that occurs from non-communicable chronic conditions. And if you look at this chart, if you, India is well above, the sort of what you would call the average or the median in this number. It's at a level that could be predicted by its income per capita, but certainly it's a pretty high number, roughly around 60 to 70% of deaths in the age group 40 to 70 are occurring due to NCDs. And even though there are interstate variations, and those findings come out from the disease burden study done by ICMR, even the so-called states with relatively low shares of premature NCD mortality have shares that are well above what you would call the global average. So certainly, premature deaths from NCDs are an area of important concern, and certainly for a country interested in exploiting its demographic dividend for economic growth. So from an economic point of view, this is not a good thing, but also, of course, from a health point of view, also not, because they're getting health conditions much earlier, and therefore long periods of disability and lack of functioning. So that's a big issue of concern. The other stylized fact I want to draw your attention to is the large share of the private sector. This is not a surprise to anybody in the Indian health sector. And this is not just in financing, although I've given the financing charts here. Roughly around 60% of all spending in the health sector today, this is all based on national health accounts for India produced by the Ministry of Health and Family Welfare. Roughly around 60% of health spending is from the private sector, of which around 52 percentage points is from out-of-pocket spending, and around 7 to 8 percentage points from contributions to health insurance premiums. Large number, but much of this money, by the way, is spent also on private care. So the private provision sector also is a major player. So we have basically a significant player both on the financing side and on the delivery side in the form of the private sector. In fact, you would probably say that the Indian health sector is dominated by the private sector in many ways. And at some level, this is where the motivation for this study comes from. What exactly does it mean? Is it an issue of concern? So here's where the concern comes from. I think if you ask health experts, why do we care about a lot of private spending? Well, that's because it's probably a very inefficient way of spending, especially if it's done out of pocket. And if you look at India, what's happened in the last decade or so, and this is again from National Health Accounts data from the ministry, although it's been declining over time, it is still a large number, well above what would be given by India's income per capita, which is the diagram on the right, but also almost 52% of India's, again, health spending is on account of this. So a large number, and since it's not pooled, it is probably the most inefficient way of thinking about financing healthcare. So that's where the driver of this particular study comes from. And the question we ask ourselves all is, well, what is, if any, is the link between these two sorts of events? How, as a society is experiencing aging and a growing burden of chronic conditions, how is this aging and NCDs interacting with what's happening in the private sector side in terms of the out-of-pocket spending and generally spending in the private sector? Are there possible policy lessons that we could learn by understanding better what's happening with chronicity on the one hand and out-of-pocket spending on the other as a policy guidance to governments. That's where but of course, if you think about this just a little bit more, you might also say, well, why limit ourselves only to NCDs? You could apply this logic to literally any health condition. So that's another. So in fact, that led us to another step, to perhaps even look at some non-chronic conditions as part of this particular study, looking at basically the interaction between healthcare, health-seeking behavior, and of course out-of-pocket spending in that context, hoping to shed some light on what might emerge from there. Now, in this, we were helped by the fact that not all states behave the same way when it comes to out-of-pocket spending. So there's some considerable variation. Now, of course, there are some outliers like Kerala, which are well above this. But in generally, what one can observe is there's some significant variation across states in the share of spending allocated to out-of-pocket in India. Now, what it might lead to you to suggest, and that's what we thought, that perhaps understanding this better could give us some insight into which states have better functioning health systems. So that was sort of the immediate next step. So what this study is really about is investigating, looking at conditions, health conditions, how these translate into health-seeking behavior in a context of a significant private sector, what that implies for out-of-pocket spending, and what that implies about how well-functioning health systems function. So that's basically a series of thoughts. Now, we haven't answered all of these different things along this logic, but certainly I believe that you see from the findings that we've made some headway in this discussion. Now, the questions, again, this is again building on what I just said. Essentially, we asked 3 questions as part of the study. The first one was, what affects the decision to use services? And what are the factors that influence choice among different types of healthcare providers? The most basic of the questions in this context, public or private, formal or informal, and so forth. The second set of questions we posed for this work was, well, typically treatment-seeking behavior is not a one-shot event. It's actually a sequence of events going to different providers and so forth. So what do we know about the healthcare-seeking pathways, and how might these differ across different types of health conditions? Because these pathways can often be quite long. And of course, as you can imagine, that's bound to have some sort of an effect on out-of-pocket spending. And finally, the third question, which is bringing together the link between the disease burden on the one hand and out-of-pocket spending on the other, is what are the implications of this sort of health-seeking behavior on indicators of out-of-pocket spending, severity of out-of-pocket spending. We call them indicators of catastrophic spending or medical impoverishment and so forth. So that's basically those 3 questions that have driven this study. 3 types of analyses, and written in this single PowerPoint, it looks like it's a very small piece of work. It's actually a huge amount of work that went into this. But basically, there were 3 types of pieces of work that went into this analysis. One was an analysis of existing data sets, and that includes things such as the national sample surveys, healthcare utilization expenditure surveys, and the IHDS, which is, of course, NCAR's own highly important set of surveys. We also undertook our own household survey as part of this work, focusing on health-seeking journeys of patients with conditions that I'll talk about in a minute. And of course, we couldn't choose every single condition. We had to make decisions about them, and you'll see which ones we used. And so that's the data that's collected from 4 states. Again, Uttar Pradesh, Maharashtra, Punjab, and Odisha. And finally, to sort of, nowadays it's sort of well appreciated that quantitative findings offer only one dimension of what's going on in patients' lives. So the third part of the work essentially took a very deep dive into using qualitative research methods as to what's happening in terms of treatment-seeking behaviors of households with patients with these conditions. Again, going back to the idea that we might get some insights about better functioning health systems from less better functioning health systems by looking at how people who fall sick choose services and how much they spend. We thought we'd look at 2 states with what we perceive to be well-functioning health systems, Maharashtra and Punjab, and we thought we'll compare them with 2 others which we thought weren't functioning as well, at least a priori, which were Odisha and Uttar Pradesh. So that's where these things come together. Now, in terms of the three conditions that we looked at, after a lot of discussion, we arrived at these three. The first was to look at chronic respiratory conditions. Initially, we thought we'd look at COPD, which is a particular kind of respiratory condition, but realized very quickly that it was going to be very hard to identify that in clinic. I mean, you need a whole bunch of specialists to identify that. So ultimately, we settled for chronic breathlessness, which could, of course, refer to a range of conditions, asthma, COPD, and so on. The second class of conditions we looked at was what we think is actually a significant disease burden. And particularly in the case of women, it could be quite important and tends to be underreported. And this was a whole suite of gynecological conditions among Indian women. So that's the second class of conditions we looked at and in terms of health-seeking behavior, care-seeking pathways, and out-of-pocket spending. And finally, we looked at acute respiratory conditions among children, 0 to 5. And that, of course, has the advantage of not only offering a comparison between what we call traditional non-communicable conditions with an acute condition, but also it gives a chance to look at what might happen, what affects health-seeking behavior for these different types of conditions. I should offer one caveat that in defining these conditions and looking at how people behave in terms of healthcare seeking behavior and how much they spend, we looked at conditions that met a certain threshold of severity. That is, we actually asked the respondents if they had this condition at a level severe enough for them to consider seeking treatment. Whether they sought treatment is a different story, but something that they considered seeking treatment. So that's, in some sense, this is not any condition. It's a condition that satisfies a particular requirement of the threshold that people considered seeking treatment. So if you have minor cough, that's not going to be considered part of this particular study in terms of gathering data from respondents. So let me now invite Prabir Ghosh to talk about the next piece, part of this presentation, which is focused on survey design and methodology that was done for this survey work.
So, thank you very much. Good afternoon to all. And 8 to 10 minutes?
Yes, 10 minutes.
So, now I will be discussing the survey sample design and survey methodology. First, I will discuss how we have selected the states. Basically, 4 states, we chose 4 states that Ajay has already explained. 2 states that reflects the high performance in the health system, Maharashtra and Punjab, and 2 other states that reflects the low performance in health system, that is Uttar Pradesh and Odisha. Actually, the Niti Aayog, since 2015-16, you all know that they have been publishing the health report, and where they have ranked all the states based on certain indicators, health outcomes and key inputs and governance issues. And we generally took the data for 2018-19. And if you compare over the last 3-4 years health index data, then you will get hardly any difference between the ranking. So, and we have categorized all these states and UTs into 3 categories based on their scores: low category, low performance states, then medium performance states, and high performance states. And from the high performance states, we have chosen 2 states randomly and selected Maharashtra and Punjab. Similarly, from the low categories, low performance states, we selected another 2 states, that is Uttar Pradesh and Odisha. So this is all about the selection of states. Then we come how we have selected the districts. It was decided that, it is proposed that, it was decided that 2 districts were selected from each of the 4 states, and that district selection was based on one indicator that is mostly available by district, that is the percentage of women who made minimum 4 visits or more of their antenatal care during the last birth. And in that way, we got 2 districts, Firozabad and Chandauli from Uttar Pradesh, and then Bargarh and Thenkaran from Odisha, and then Kolhapur and Javatmal from Punjab, and Moga and Hoshiarpur from Maharashtra. Besides, So this is the last minute. the Actually this slide, yeah, this presentation was revised by 4 people, so there may be some issues in the last moment. Yeah, sorry. So besides this indicator, we kept in mind the diversity among the across the districts. So you can see the diversity. In Uttar Pradesh, we have selected Faizabad in one set, another one the Chandoli. Though their median value of that percentage of women having 4 or more antenatal care was the more or less same. Then we selected Bargarh in one set and then in the other side. Similarly, in other 2 states, Jawadmal, you can see Kolhapur and Jawadmal, yeah, Maharashtra, and in Punjab, Moga and Hoshiarpur. Then how we select the samples, PSUs, then households. For sampling purposes, first we selected the PSUs, consists villages and urban blocks, and then from each PSU we listed the households and stratified by health conditions, and from each and then from each of the selected PSUs we selected randomly the specific health conditions by districts. And of course, it depends on their availability, the number of cases in each PSU. Then selection of PSUs. A minimum of 125 primary sample units were selected, and these 125 PSUs were distributed by rural-urban based on their proportion to the share of population. So then we allocated the number in rural and urban. And the allocated number of rural villages we selected from we took the data from the census 2011 village data, and we categorized all the villages into 3. We grouped all the villages into 3 categories, low, based on the female literacy rate, and just low, medium, and high. Then the allocated number of rural PSUs were distributed by these 3 categories based on their proportion of population in each category. So once this is done, then from each category, the allocated number we selected through PPS method, and here village is the size is the population of the village. Similarly, that I have already told, and similarly the urban PSUs, the allocated number, to get that allocated number, we selected from the urban ward, and those wards we have selected through PPS method, and size is here also the population of the ward. Then from each ward we selected 1 PSU for the survey. So this is the distribution by rural and urban of the allocated number 125 PSUs per district. So you can see the rural-urban distribution by states, and in total we received 1,017 PSUs, and out of this around 25% from urban areas and another 75% from rural areas. Then we listed the PSUs. From each PSU we listed around 125 households with the segmentation approach. Segmentation approach like this: all households in PSUs with less than 125, all had been listed, and then the PSUs where more than 125 households were segmented and selected randomly 1 segment for the full listing. In total, we get around 126,000 households for the survey from all the sample districts. So here also you can see the distribution by rural-urban by states. So here also we can observe that 24% from urban areas and 76% from rural areas. Then the question of selection of conditions and distribution by rural-urban. From each of the PSU, we selected around 3 to 5 households that were randomly picked up within each condition, and obviously depending on their availability. So this is all about the sample design up to the household level. Now the survey methodology, we developed 4 types of questionnaires. household listing questionnaire, the child questionnaire, adult questionnaire, and women questionnaire. And these questionnaires were translated into local languages while canvassing. And the content of the household questionnaire, we captured household characteristics and details on members with 3 specific health conditions through household listing questionnaire. And for the main questionnaire, for the main interview, we captured household characteristics, then treatment seeking pathways, then consultation since identifying the diseases, then healthcare access, the healthcare expenditure, and the health insurance, the perception on quality. Then besides these health indicators, we also captured the household income, expenditure, basic amenities, and ownership of assets. Altogether, about 100 survey investigators were involved in the survey work, and out of 100, around 80% were female investigators, and the survey was done using CAPI. And the limitations, we jotted down few limitations here. Actually, the survey was conducted in different time periods, and due to COVID-19, that I will explain the next slide, how and when the survey was done. Then there is an issue of recalling information, like it happens in every survey. So in this survey also, like use of different healthcare providers, associated expenditure, and history since beginning, etc. So it took time to recall, and sometimes they had to take the help of their son or father or mother-in-law or father-in-law, such things. 1 minute. And the female respondents often accompanied, another limitation was that the female respondents were often accompanied by other family members. Because in what we observed in the field, in some cases, particularly the married, unmarried girl and married young women, so they are not allowed to interview alone. So in those cases, so either their mother-in-law or their sister were accompanied during interviews. So as I told you that this is the survey period. In the first phase, we completed the survey of 2 states, Uttar Pradesh and Odisha, in June to October 2019. Then when we started the survey in February 2020 for the remaining 2 states, then after 10% of the survey, we had to stop due to COVID. And after the COVID restriction withdrawn, then we started again in Punjab and Maharashtra during March to May. So you can see how many PSUs we received in each period. So thank you. This is all about my presentation. Now I think Barbara will explain.
So yes, I'm going to very briefly tell you about an additional piece of analysis we did of secondary data, but my presentation is going to primarily focus on the findings from the survey that Ghosh has just described how we conducted it. But just a quick visit to this piece of work we did using secondary data analysis using National Household Survey data that was routinely collected. And we just asked this question: is there an association between public spending on health and choice of healthcare providers across socioeconomic groups in India? In other words, if there's more public spending, how does that influence who goes where to search for care? And in particular, do we see that with more public spending, we get better public health care that's recognized by patients and they use more public health care as a result? And this is the paper that you can look up. As I say, I'm just going to very briefly tell you about its finding here. And the simple answer is yes, indeed you do, and to an extent that I think surprised us all, in that for each 100 rupee extra per capita spending at the state level, we got quite a substantial shift across the whole population. About 7% of uses of healthcare would shift from private to public, and for the poorest it was 17%. So you get a very substantial impact of increasing use of the public sector when you spend more money on public health expenditure. And I think that sort of runs in the face of this idea that I quite frequently encounter in India, that spending on the public health sector is a bit of a waste of time, it's just a bottomless pit, it never gets any better. But this suggests otherwise, that it's actually well worth doing, it's a good investment, and I think that's a theme that we'll see coming out of our survey as well. So moving on to the survey, that's the main point of my presentation and the main thing I want to talk about. And I'm going to talk about the answers to two questions. One is, to what extent from the health-seeking behaviour data that we've collected, can we make judgments about how well-functioning the health system is in each country? And there are a lot of problems with the ways that we measure health system function. We don't really have, real gold standard measures for the functioning of the health system. So this is part to try and contribute to the conversation about what constitutes good health system function and how we can recognize it when we see it. And the second part of my presentation is about what we call an anatomy of out-of-pocket spending, a deep dive description of how out-of-pocket spending varies across the three conditions, varies across the 4 states, and varies, for example, between urban and rural, between men and women. And I'm only giving you some of the highlights from these analyses just now. The full analyses you can find in the reports that we launched at the beginning, so do pick up a copy of that if you can. So let me first of all just talk about this kind of alternative perspective on health system function that I think health-seeking behaviour gives you. If you look at the indicators that are used to monitor universal health coverage globally, and there are regular reports reporting the state of the world as far as achievement of universal health coverage is concerned, and I believe the new report came out either yesterday or the day before, very recently, and I haven't had a chance to look at the most recent one yet, but these are fairly regularly published, annually or biannually, I can't remember, and they have 3 different kinds of measures in them. One of them is measures of service coverage, and we have very good measures of service coverage for maternal and child health care collected by DHS surveys that have been implemented around the world for a very long time. But the state for non-communicable diseases and chronic illness and adult ill health is much less good, especially for measures that are available globally. And consequently, we have a very biased set of measures that has lots of detail about maternal child health and infectious disease and is very approximate about non-communicable diseases. So for example, for hypertension, they just tell you to what extent is there a problem of hypertension and use that to infer that if there's not a problem, it means that the health services are controlling people's hypertension. Of course, it could mean that, but it could mean a lot of other things as well. So it's pretty poor. Secondly, there's no quality measurement in those. And I see I've got 2 bullets the same rather than the second bullet that I wanted to have, which is that the second area of indicators that the monitoring reports use is about health impoverishment. So particularly looking at out-of-pocket expenditure and whether as a proportion of people's incomes or people's disposable incomes, it looks too high and it looks like it's potentially impoverishing, that people's encounters with the health system are consequently impoverishing. And the third area is measures of health security. Some of you will be aware of the reports on the Health Security Index that was widely used before COVID, and its very poor predictive capacity of who fared well and who fared badly during COVID. So again, our measures for health security are also not very good, but they're not primarily our focus this afternoon. So we think there are a number of measures from the kind of data that we've been collecting that aren't just telling us about out-of-pocket expenditure and catastrophic expenditure per se, but are giving us insights into how well different health systems are functioning. So we have the idea of the health expenditure transition. We can see if we look around the world that middle-income countries are converging on high-income countries' patterns of expenditure, rather obviously in relation to declining overseas development assistance. Overseas development assistance is, of course, concentrated in low-income countries, but that what we're also seeing across the world is increasing as a proportion of GDP levels of public domestic health spending, increasing pooled finances, so less out-of-pocket spending, more insurance, whether it's public insurance or private insurance, and declining out-of-pocket expenditure. And we can see that as purely descriptive, that's how the world is, or we can see it as normative. This is improving, an improving pattern of health expenditure, and therefore we can suggest that as we move towards that further state, that's an improvement if we believe it. It's a normative idea. Then there's another idea about distress financing. If you can fund your access to healthcare with excess income, money that's in the household or through running down savings, that's seen as much less liable to be impoverishing than if you're using, if you're borrowing money and getting into problems of money lenders' obligations, or if you're having to sell assets that are things you rely on for the future well-being of the household. So those second two things are known as distress financing. You would only do those things because you have no choice, and they have quite strong risks of impoverishing you in the longer term. Then thirdly, we can think about the choice to consult a private provider, because if you consult a private provider, and given that private providers are much more expensive, it means you don't think much of the public sector, right? If you could get public sector care free or very low cost, you would use it, except for that you think it isn't very good. So the sign that people are, even when they're not very wealthy, using the private sector is a sign in itself that the public sector is not functioning very well. And then the last one is just simply not seeking healthcare. And remember that our conditions are all conditions in which we've asked people to, whether they consider them serious enough to warrant seeking healthcare. So if people don't seek healthcare when they've considered it serious enough to seek healthcare, it does suggest there's a problem. And we'll come back to some of those things. And the question for us is, to what extent do these kinds of measures agree with the kinds of measures that Niti Aayog produces in their health system ranking exercise that Ghosh told you we had used to identify the states that we went to, and saying these are high-performing states, these are low-performing states. Do these kind of data agree with that perspective? Now, I don't expect you to take on board all this data on this table all at once. I'm just giving you a sense of the data that I'm using for the analyses that I'm about to do. We've taken each of these different measures that could be used. Yes, do move forward if your glasses could do with an upgrade. We've got all these different measures of health system function potentially from our data. You can see how they're distributed. But the way that we've looked at them is using these spider diagrams as a way of capturing all that data in a way that's a bit easier to understand. So each of those measures can be considered measures of good functioning health systems or bad functioning health systems. And the way we've organized this is if it's good, it's close to the center. We've scaled it to 0. If it's at the bad end, we've scaled it to 10. And you can see the different states in the different colors on this map as kind of areas. The smaller the area taken up by that shape that's drawn in each of those colors, the better the health system according to these measures. And quite surprisingly, when you look at this chronic severe breathlessness condition, the smallest space taken up by one of those shapes is Odisha's. And that, on the other hand, is according to Niti Aayog, one of the poor functioning health systems of the country. So we get, just in essence, some very different pictures of whose health systems are working well and who's not from these figures. And then if you look at the largest shape here, is probably Maharashtra, and again that's one of the well-functioning health systems according to Niti Aayog. So that raises a lot of questions. I'm not saying we're right and they're wrong, but there are very different ways of looking at this, and it gives us very different insights into what's going on. And what we can see in Odisha is that there's much more use and apparently trust of the public sector in Odisha than there is in the other states. And that's protecting people from out-of-pocket spending. It's protecting people from having to borrow or sell their assets. It's enabling them to access healthcare. So it's doing a lot for them that they seem to have better trust in their public system, at least when they have an adult health condition or this specific chronic severe breathlessness. And when we look for acute respiratory infection, the answers are fairly similar. Odisha looks quite good, although it doesn't look so clearly best. Maybe it's Punjab that looks best here, and that is one of the ones that is supposed to be a better functioning health system. Maharashtra still looks terrible. But if we look at the chronic gynecological conditions, the situation looks very different. And here we see Odisha doing much less well. So why is that? Is that because women don't trust the public health system for their intimate condition? It's obviously a kind of condition that many people feel embarrassed to go to a health facility for example. Is it just a male-female difference? We can ask all these questions, but what we can see is that health systems don't function equally well for all conditions. So we need a more nuanced idea of what is good health system functioning, and we need a more nuanced set of indicators that can look at it from more perspectives, in my opinion. Okay, let's move on to the out-of-pocket spending findings from the survey, and I suspect I'm running out of time, so I'll go through these fairly quickly. I have 6.5 minutes, that should be enough. So we have a number of tables here, and I'm just going to give you some highlights from them. Again, we have the full report, and you have the QR code, I think, to access that, so you can look in more detail. But if you look at just, what do people spend more money on, we can look at across the bottom row of this and see that indeed chronic respiratory disease is the most expensive, is where people spend the most money. And that's very much anticipated by the existing literature. And if you look at the simple unweighted averages of how much people spend in the different states, I haven't weighted these by the number of people in each box. We can see that Maharashtra's health expenditure is highest, but followed by Uttar Pradesh. So we have a rich, supposedly well-functioning health system spending the most, and then a poor, supposedly poor functioning health system spending the second most. So it's not altogether clear what's driving these differences. And if we look by category, we find what I think is well known again in India, that medicines is the largest share of all the out-of-pocket expenditure. It's about 50% for each condition. And this 50% number is surprisingly persistent, no matter how you chop the data up. And to my mind, it raises some questions about whether this is more about the pricing structures and pricing strategies of providers than it is really about the distribution of costs. Because it seems to me that it doesn't make sense that medicines is always about half the cost. But it does make sense that perhaps people are more willing to pay or complain less about paying for medicines than they do about more intangible things like doctor's time. So I wonder whether this truth that medicine is always the largest share needs to be a little bit more drilled down on and ask, well, do we actually know that that's about the cost distribution as opposed to just the pricing strategies, which obviously can diverge. So that's a question, I think, for any of you around the room to perhaps give us some wisdom from inside. Then we can look at the proportion of households incurring catastrophic health expenditure. And we did something, I don't know if it's quite unprecedented, but we looked at catastrophic health expenditure at a very high degree. We looked to see how many people, routinely we might look at how many people spend 10% of their annual household expenditure and call that catastrophic health expenditure. There are many different thresholds, but I've never seen any other study that has looked at 40%. So people spending 40% of all the money they spend in a whole year on one episode of healthcare. it's mind-blowing. I can't imagine having to spend 40% of my whole household's income on one episode of healthcare. And the reason we can look at that is because our population is a population with severe illness. If we were looking at a population with, you know, a random distribution of illness, we'll just get very tiny numbers in that category. But what we can see is that once somebody has a significant problem in the household, it's not so rare to be spending at that extremely high level. The top number at the 40% level on this table is Maharashtra for chronic respiratory disease, where 6.7% of people with chronic respiratory disease in Maharashtra spend 40% of their household's annual income. And I think that just really underlines the point that Ajay was making at the outset about the highness of health expenditure, of out-of-pocket health expenditure in India. And in pockets, it's 6.7%. I should have introduced that B2Q and T2Q. You're probably all sitting there wondering what they are. I'm talking about the bottom two quartiles of the household expenditure distribution and the top two quartiles of the household expenditure distribution. We normally talk about quartiles or quintiles, but because of the numbers, we really need just to divide the population in half to get large enough samples. Right, I have 2 minutes, so I'm going to hurry up. This figure I'm not going to explain in detail, but it shows you that the more extreme is the level of catastrophicness of the expenditure, the lower is medicines as a share. So that gives us another piece of food for thought about how these structures are arrived at. I can look at share of out-of-pocket expenditures as a percentage of the total by visit, and what that shows you is that people spend nearly all their money on their first visit, and I'll come back to that point and explain why I think it's important. We can look at the breakdown of out-of-pocket expenditure by provider type, and we can see that the private sector is very dominant in out-of-pocket expenditure, except in Odisha, where so many more people use the public sector, where public sector expenditure becomes more important, but is still not the most important. And we can look at, sorry, did I just go up? I did. And I don't have time to explain these regression results in great detail, so I'm just going to jump to this next table, which shows you one thing that I want you to take home from all this, and then please do mull over the rest of it in your own time. But what's consistent across all the conditions, this just shows you the regression coefficients for chronic respiratory disease, is that there's a very high coefficient and a very high significance of the coefficient attached to using the private sector. So, and if you look at the mixed coefficients there, you'll see they're also high and significant. That means people mixed private sector and public sector, but they're consistently lower, which shows you that any use of the public sector in your health-seeking journey is somewhat protective of ending up with high out-of-pocket expenditure. So, some conclusions. I think most of them I've made, so I'm just going to, because I'm short of time, I'm just going to pick out a couple of new ones here, or perhaps not so much new. I think I'm going to go back to that point about the share of total expenditure that happens at the first episode. I think that people have not documented that before, although you may know studies I don't know. And what it tells us is that the use of routine health data to always ask people about their last visit to a health facility is a bit confusing, because if your last visit happened to be the first visit for your episode, it's going to be most of your expenditure. If it happened to be some later in your health-seeking journey, then it will be a much smaller level of expenditure. And it seems to me that this suggests that we should at least ask, was that the first place you went, so we can put the data that we're getting from those last visit data into some kind of context. I'm not going to go through all the other boxes. Hopefully you're having a chance to eyeball those as I'm talking. I'm just going to underline the last point on the slide, which is the importance of access to good enough healthcare. In other words, healthcare that you trust to be adequate and better than going off and ending up being impoverished by private sector encounters is going to be massively important for universal health coverage, yes, as we know, but also for poverty reduction in India. And if poverty reduction is to continue on the pathway that it has done for the last couple of decades, I think attending to these health expenditure issues is going to be critical. Most families are going to have somebody with a severe chronic condition, maybe once every 10 years, a new chronic condition for a family. And if it's as the tendency to impoverish people that we can see here, that's going to have a very major impact on the ability of people's efforts to lift them out of poverty in the longer term. I am done. Thank you. I shall hand over to Sumit.
Thank you, Barbara. Thank you, Ghosh. Thank you, Ajay. And thank you, everybody, for being here. So I'll walk you through some of the qualitative findings. And we did this qualitative work. We conducted in-depth interviews in 20 villages across Uttar Pradesh and Maharashtra, across all the 4 districts. So Chandoli and Firozabad in UP, and Kolhapur and Yavatmal in Maharashtra. I hail from Maharashtra, and I've lived for many years in UP, so that was also somehow the reason to choose these sites. We spoke to 41 very purposively selected respondents. These were part of the same group of people who were in our line list. And as the surveys were being conducted, we worked with the survey teams to identify respondents who we figured would be insight rich. The vast majority of participants identified themselves as being poor or of modest means. And our exercise was to figure out what people's care-seeking journeys are like, what their care-seeking experiences were like, and what drove them to choose to do what they did. Very broadly, and we've mobilized a whole range of conceptual ideas to make sense of what we were encountering. But very broadly, we began by taking Wigg's work, the concept of navigation across social worlds, as the starting point for approaching our inquiry, and looking at care-seeking as an act of social navigation. So in this presentation, I'll present 2 sets of findings from the qualitative work. There are 2 or 3 other bits that are being developed, and you will see papers coming out. The first set relates to people's care-seeking journeys. We've published this, and you have it in your dossier. And this was focused on and drew primarily on the experiences of those with chronic breathlessness. So as we were analyzing our data, we realized that what we were encountering were a whole range of journeys with something in common, 2 stages almost to the journeys. And that aligns with what we have found in the survey. The stage 1, which was more around the first set of visits, and this was around running from pillar to post to figure out what have I got, what is going on with me, and how can I take care of it. And in the following sets of quotes, I try to illustrate to you, and I'm sure you will recognize it, the kinds of things that people were thinking about, they were doing, and what was driving their decisions. We heard people say things like, we went everywhere, whichever doctor we could, whoever was available nearby, and we may have gone to at least 10, 15 doctors. We take it with a pinch of salt, of course. 10, 15 is a figure of speech, but the sentiment is important that they were running from pillar to post, trying to figure out what was going on. Another important feature we recognized in terms of what drove people to do what they did and to explain some of the data that Barbara showed you about the first visit was, I wanted to be cured no matter if it was at a government hospital or private hospital. And the hope of getting rid of the illness by its roots, and you all recognize this idea of the illness having a jad or that kind of a thing that can be taken out, was encapsulated in one of these phrases that we heard all the time. People in Uttar Pradesh talked about bas jad se nikal jaye, bas khatam ho jaye. In Maharashtra they talked about exactly the same, muat na nigun jawa, usko ukhad ke fenk dena. That kind of a sentiment drove the very early care seeking, and it drove people to desperation is what we figured. They were running from pillar to post to find a mythical cure for chronic illness like chronic breathlessness, which somebody should have told them that they were going to live with for a very long time, perhaps forever. So the analysis that we have, these are the points we try to make. This desperation, when compounded by the lack of reliable and trustworthy sources, as Barbara was saying, sources of advice and care at the point of first call, renders people vulnerable to being misled down wrong paths, to being exploited by unscrupulous, profiteering, and often unqualified providers. People are desperate, the charlatans take them for a ride. And that is what is reflected in our data. The first visit, you see a whole lot of expenditure. This vulnerability, we argue, is amplified at the intersection of worry, the urgent search for cure I just talked about, the hope for cure for an illness they are clueless about often, but also by a curious mix of the desire to do the right thing for one's loved ones. There's nobody to give you the right advice, so you take it upon yourself that I want to do everything I can to leave no stone unturned. And crucially and interestingly, and you will all recognize this, also the desire to be seen by each other within the family, but also by society, that we have done everything that is possible. So people carried this badge कि मैंने तो मेरी गैया बेच दी, हमने हमारी ज़मीनें बेच दी, as a badge of honor. Because no way to get the right advice, no way to get good guidance, and what do? You resort to these kinds of things, and I'll come back to it later in further slides. These are the kinds of traditional healers and unqualified jhola chaps. The idea of the jhola chap kept coming back again and again. People recognize these providers, they recognize these are suboptimal care options, but that's where they go to no matter what. And we are writing a separate piece on it, hopefully an interesting contribution. The second stage of the journey, curiously, is about exhaustion, reconciliation, and acceptance of almost their fate. And this is the kinds of things we heard. This disease has broken me in all ways possible. And this was very hard to hear when a 65-year-old man with tears in his eyes tells you, when a 70-year-old woman says, this is what it has done to me, it has destroyed me. People talked about how the poor had no option but to go to the local unqualified providers, irrespective of the treatment they give, irrespective of the treatment we receive. What else can we do, and so on and so forth. Talking of chronic breathlessness, this is what we heard again and again. Ye dam to dam ke saath hi jayega. So after having lost everything, often, this is where people settle down. And what does it mean? It means we see the emergence of this battle-hardened, experienced patient who is calculative, pragmatic, and focused on getting relief, no matter what. But we argue that this patient, pragmatic patient who's focused on getting relief is differently vulnerable to being medically mismanaged. And what we saw with chronic breathlessness was people being given steroids with very clear symptoms and signs of steroid overdose for years together. Being given wrong treatments wrongly. People being given high-dose antibiotics unnecessarily because somebody just felt like that was what was working. Patients here also need and are looking for reliable and responsive sources of advice and care close to their homes. So even if they are further down in their journeys, the needs are exactly the same because of the need for continuity of care. The second set of major findings relate to what, and the paper just got accepted yesterday, so it should come out in the next 2-3 weeks, is the logic of a kind of a moral economy of the family. And some of it I've touched upon here. And the point we are trying to make is that social norms and values shape household healthcare expenditure and resource allocation related decisions. And norms and notions of selflessness, duty, sacrifice, being the good son, being the good father, being the good brother, all of those fundamental, foundational features of a family, they help the family to cope with making these complex decisions. Selling one's house, selling one's land, foregoing education, all of this happens within this moral economy of the family. But these very norms and notions are also the kinds of conditions whereby families, particularly the poor, end up overspending and often impoverishing themselves, signaling to each other signaling to the larger society that we have left no stone unturned. We have done the right thing by our family. So this moral economy of the family needs to be invoked by people again and again because they have nowhere to turn to get the right kind of advice. So this is the fallback option. This is what it results in. So two broad sets of findings in terms of conclusions or key takeaways from the qualitative study. Family level expenditures and resource allocation towards healthcare are driven by social norms, gender norms, and we need to be aware of it if we are planning any interventions. Echoing what Barbara pointed out from a survey analysis, the point of first call of care is critical. It sets one on a particular path in the care-seeking journey. If one gets it right, the odds of one being impoverished and the odds of one receiving the wrong kind of care fall dramatically. Some obvious findings: the poorest in financial terms, social terms, and relational terms, and the who knows whom terms are the most vulnerable to being set on paths of exploitation and ultimately impoverishment. There are different vulnerabilities at different stages of the journey, but everything boils down to and can be reduced to good primary care close to home, which people can trust, people can rely on. Our findings importantly also show that whenever such arrangements are made, and people have said it again and again, people will use these kinds of close to home, even if simple, good quality care. This is what they say. If there were better facilities provided in government hospitals, hospitals said generally, why would one go to private hospitals and spend so much money? People recognize that, and as Barbara showed in her secondary data analysis, they will vote with their feet. So that's the key set of takeaways from the qualitative work. I've got 2-3 minutes, Ajay, still?
You've got 1.5 minutes.
Okay.
I've cut another half minute.
Okay, very good. Another half minute has been cut. But these are some of the overall conclusions and discussion points that we've talked about. Our discussants will also touch upon them. But our evidence broadly supports the argument that public health expenditure, investments in public health, translates into better health system outcomes in terms of improved access to more reliable sources of care and reduced health expenditure. And it does not support the argument that public health expenditure is good money thrown after bad. So it is, we're very sure about it, at least from our data. Health system contexts where out-of-pocket spending by households is the norm and they have no reliable source of information guidance, it is important to recognize that allocation of resources towards healthcare will be driven by these kinds of nice family values, but they lead to messy results, impoverishing results. Again, repeating, the early stage of the care seeking for any chronic condition is critically important. It is important for health, what it means in terms of getting better, but it has economic consequences too. People need and want trustworthy advice and care at their first point of call, including to better support navigation in higher levels of care, whenever they need to go to higher levels, secondary or tertiary levels of care. This point of first call needs to be good quality, and we argue public primary care services are ideal for this. Our contention is that the Ayushman Bharat initiative of the Government of India has the potential to support these directions. The Health and Wellness Center and the primary health centers, the massive network, both the new and the old, that we all at the moment have the potential to step in, to be improved and strengthened, to play this role. In good time, thank you everybody.
Thank you very much. Sajid, you want to go first?
Good afternoon, everyone. The dignitaries on the dais as well as all the participants. First of all, I would like to compliment the entire team for doing years of study on this project. I think they started in 2019 and continued till 2022, and in very difficult time. And they have come up with a range of findings, very enlightening ones. And as a person sitting in the finance department, I am very happy to here, it's like music, that if you spend money on public health, it's public money, if the government spends on healthcare, it's not going down the drain. It's being used, and it's going to change the health-seeking behavior of people, and it's going to reduce out-of-pocket expenditure on health and so many good things. And there are so many other findings related to specific health-seeking behavior as well as related to certain chronic conditions which we have put. So I find that they are all extremely good, a lot of learning, and this report should reach to different levels in the government where they can use these findings. That's what we want. The impact of health research should come in terms of translation into policy making and policy implementation, so that there is value for money spent on health, on this research. So from the government side, there are so many kind of information I would like to share, just because the study has been presented, and Sumit has touched upon that the initiative of health and wellness centers is doing well. And I also am very sure, I have seen it from both the sides, from here in the ministry and when I worked in the field in Daman and Diu Dadra and Nagar Haveli recently from 2017 to 2019. We had started implementing these two very important initiatives of the government under the banner of Ayushman Bharat. One is Health and Wellness Centers, and other is PM Jan Arogya Yojana, both started in 2018. And as per my information, so far 1,61,835 health and wellness centers are now functional. So what's the change in, because the sub-centers were there earlier, PHCs were there earlier, what's the change in this health and wellness centers? So change is that, one, change is in terms of the range of services which has come into these. Earlier the sub-centers were just A&M centers, it is just for antenatal checkup and small medicine dispensed. But in terms of range of services, in terms of infrastructure, in terms of integrating the traditional systems of medicine, Ayurveda and our indigenous systems of medicines with the allopathic system, and kind of health awareness they are generating through surveys on NCD, through their events happening in the health and wellness centers, and like there are blood tests, there's yoga classes, there are screening for hypertension, all that. So I think that change is slowly coming, and it will be more visible as we move, as the time passes. This massive number of 161,000 health and wellness centers are going to change health-seeking behavior and quality of care at the primary level, at the doorsteps. Second, Pradhan Mantri Jan Arogya Yojana, again another pillar of Ayushman Bharat. So as far as I know, that presently the scheme covers 12 crore households, it covers 50 crore people, and there is some data which I have which shows that out of 100 people insured right now, 4 people on an average are kind of getting benefit of this scheme, which is quite good in terms of the morbidity, mortality and the need. And the average kind of spending per person under this scheme is 13,000 rupees per year, which is going to make a dent on the out-of-pocket expense in the times of come. And I'm sure the scheme, the coverage will go up in the times to come, because a lot of families who are eligible are still not in its fold because of, I am sure it is because of the poor quality of data which is there in the socio-economic caste census, which forms the basis of choosing the families for this scheme. So while I was in Daman, we encountered a lot of problems in searching for the families who were there in SECC data, and this survey was conducted in 2011, and quality of survey in many places is not so good, so it's very difficult to identify those families, and other families can't enter. So government recently allowed the states to choose families from other databases to meet this target of 12 crores, and I'm sure the more and more families will be getting into this fold, and this will benefit people. So in terms of public expenditure on health, I saw some data from and I analyzed some budgets of the state governments and the central government. So you have the data till 2021, I think. So in terms of absolute value, the expenditure which was 1.75 lakh crores in 2015-16, it went up to 3.8 lakh crores in 2021, and in 23-24 it's estimated to be 4.56 lakh crores. So its government has a lot of focus on health, both in the center as well as in the states. In terms of percentage of health expenditure as percentage of GDP, also I see an upward trend from 1.3% in 15-16 to 2.1% in 22-23, but we have a long way to cover, I will add that. And there is wide variation in the states in terms of percentage of their expenditure, as percentage of gross state domestic product on health, which is varying from 0.7% to 3.6% of GSDP. So many states have to do a lot of catching up. Many states are not that much focusing on health, where the expenditure is 0.7% of GSDP. It is quite low that way. So I would like to also tell you about some of the more initiatives of the government, which I think some of you would not know, many of the people would not know. The 15th Finance Commission, the Finance Commission is constituted by the government every 5 years, and it decides the resource allocation, how much of the central taxes and duties will go to the states. But it also recommends various types of grants to the states and various types of grants to the local bodies. So the 15th Finance Commission came out with this recommendation that the health systems at the grassroots level need a lot of strengthening, and they recommended a special kind of grant for local bodies, directly to the local bodies, not to the state government, not to the central government, directly to be spent by the local bodies. And the amount recommended is 70,050 crores. So this is a huge amount which is going to go to the local bodies. It is meant for construction of buildings, it is meant for setting up diagnostic labs, it is meant for conversion of sub-centers into health and wellness centers. So that is another aspect which I think not many studies have been done on its how the money is going. I would be happy if someone is interested and conducts a study on how this fund is flowing, what is the impact it is making, and it's directly released by the Finance Ministry to the local bodies. Then we have another scheme. Oh, I'll finish. We have another very important scheme in the government, which is also very recent, which is 1,30,000 crores, which is special assistance to states for capital expenditure. And in this also we are giving a lot of money for health infrastructure as well. And finally, when I did my doctorate in public health from London School, I worked on the injuries to construction workers and building a surveillance system for them. Then I realized that there is a lot of money parked in the Constructions Worker Welfare Board. And if I am not mistaken, there is about 1 lakh crore of rupees parked in bank accounts only, because there is a levy on every construction which anyone does. So this money is also very important, and this can also be used. Similarly, we have a lot of treasures, hidden treasures like BD Workers Fund, we have Mine Workers Fund. So this money is also available to the states, to the implementing agencies, so which can also be used, and many of them are using it. So to conclude, I would say that thank you very much for calling me to absorb so much of knowledge today from this finding, and my compliments for a wonderful study. And I would like to just reiterate that there is a lot of focus of the government on health sector. There are new schemes coming up, existing schemes, scope of existing schemes is widening, and our enthusiasm has doubled after hearing from Sumit that the expenditure will be very fruitful expenditure. It will help the poor, it will help the citizens of the country. Thank you.
Thank you very much, and it's wonderful being here, Barbara, Ajay, and Sumit, and the NCAER. I want to begin with what Barbara said, and I think I'll start with that, and I have some comments on the reading of your report, which I only read a summary of. I think the point that you made, Barbara, that public spending is not wasteful, is kind of a complete contrast to what we discussed in the 90s about how public expenditure is actually wasteful. And I'm happy to see that we've come a full circle now, with at least some of us, the academic world, advocating for that. And I think that as a protective function against impoverishment due to household expenditure on health, but also as kind of a bulwark for, I won't use the word regulating, but at least sort of checkmating the private sector in some form. Now, clearly that's a huge issue which can be teased out, discussed, and there are very context-specific issues there. There are a couple of observations I have, and I hope you would sort of consider it, the authors of this report, that you're looking at 4 states, and I think what I missed in the summary was that the choice of the states, and a little bit about the history of that, would be very important. 2 of yours are what were classified as EAG states in UPA 1 and 2, and the Maharashtra and Punjab being developed states with a very high private sector presence, whereas UP and Odisha, medium to high, depending on which part of UP you're talking about, eastern or western UP. And I think the role of the health sector reforms and post, the NRHM in the 2000s, specifically focusing on EAG states, and what kind of an impact did they have? And it was a differential impact, and we have quite a few evaluation reports on that across states. And Orissa seems to come out as one of the better performing states with the NRHM intervention. But at the same time, the other 2 states that you've chosen, the World Bank played a very important role in health system strengthening and pushing it for greater commercialization. And I think this particular history is important because when you're looking at these 2 states and the studies, the particular survey, both the qualitative and quantitative. So basically what I'm saying is please capture the varied histories of functionality of public health systems, and also what increased commercialization did to the behavior of the public sector itself. So that is one. And of course, you have alluded to the primary level dominated by private informal and formal practitioners and the burgeoning of the secondary and tertiary. That also, I believe, requires a certain amount of description in your work. Now, the second set of observations I have is that you're absolutely right, and somewhere in your summaries you do talk about how cross-sectional surveys themselves do not lend themselves to capture multiple morbidity resort patterns, and this becomes especially the case for long-term chronic conditions and also for older persons. And what you're actually doing, and you're doing, and there are other studies that have done this, but using a mixed methodology in a sense to capture catastrophic health expenditure, and then illustrating it through very specific health conditions. Now, what I find very interesting is this point. Yes, Odisha is an outlier from your study on for certain conditions. And you say that maybe it is due to better public provisioning, but have you seen it in relation to underutilization of the public sector? Because you're taking 2 districts, Denkanal and the other district, Denkanal being largely a tribal district. And so the question around availability, accessibility to services becomes very critical, and the geographical nature of the access also becomes very important. And therefore, I'm just wondering if those characteristics will become useful when you actually compare within states and across states. I also felt that when you're comparing districts, it may be useful to classify them according to availability, accessibility, and even the functionality of health services, some indicators, and population characteristics. So how do we actually compare a predominantly tribal district, while you look at Kolhapur in Maharashtra, which is probably better developed, and Moga in Punjab. I mean, somewhere I think the study needs to engage with these variations, which would actually enrich the kind of analysis that you do and nuance it even further. I particularly like the idea that you referred to the social gradient, and I think this is a very important idea which needs to be resurrected, because if you remember in the reform period, we only spoke about the poor. And I have a problem even with the present patterns of expenditure and investments, where you start in really privileging only targeted programs. And therefore, even when you look at Ayushman Bharat, you say that it's meant only for those who are below the poverty line. So does that mean those who are above the poverty line? So you're not really taking in the social gradient argument if you're targeting. So what is the tension in that? And that is something you probably will have to address in your work. The gender differential comes through somewhat, but not adequately. And I think that's also because your samples are small and you probably can't say very much. But there are other studies that do show gender differentials. And of course, you've used the constitutional categories of OBC, SC, ST, and general. But I think that could also be nuanced a bit more, maybe with the help of other studies that do this. Your observations and your findings for high expenditure for chronic illnesses and the stages of resort and the need for continuity of care is actually very expensive. And you also find that for other conditions, in fact, a student of mine who's looked at diabetes in rural Kanjipuram district shows you the class as well as the caste differentials, the way they play out in the daily management of diabetes. And it gets even more complicated when you have comorbidities, that is the TB diabetes, so the communicable and the non-communicable sort of coming together. I think the programs like the Ayushman Bharat, while they are important, of course, if you look at them as protective against catastrophic expenditure, they still are being seen, I mean, they are essentially a public-private partnership. And the question I have is, has it fueled the growth of the private sector, which continues to be unregulated? Because if you look at the RSBY data or even the Ayushman data in terms of empanelment of hospitals, and you see the flow of public subsidies, they're going actually back to the private sector. So I think these are concerns. So while we say increase public expenditure, I think the key question is, what are you increasing the public expenditure for? What does it do in relation to the private sector? How does it really control or is able to control the behavior of the private sector? Because the private sector is the dominant, is the more powerful, and is leading policy in very many different ways. So congratulations. And I really look forward to much more analysis from the data you have, and analysis you have produced. And my plea is, please look at some of the Indian studies in this area. There is a lot. There are both, various organizations and academic work that has engaged with regional level work. And I hope you will engage with that. Thank you so much.
My question is to you while looking at the spider webs. So, it's echoing voice. Speak like this. The two group of symptoms we are looking at is chronic breathlessness and respiratory infection. So, two states we have surveyed before COVID and two states after COVID. So, what impact you look at out-of-pocket expenditure? Because see, Maharashtra is showing more, but we have to consider that it's a post-COVID phase. So, what analysis or what in the?
I think it's clear that the problem with the comparison for pre and post-COVID is a limitation. You know, we didn't plan on COVID. We planned on doing 4 states in rapid succession, and we ended up with that COVID period where we couldn't progress. So it's a problem, and I don't think we can say that we know that differences are not COVID, that they're something else. On the other hand, we do know that Maharashtra has relatively high out-of-pocket spending levels when we look at contemporaneous health sector expenditures. So while I absolutely can't do anything about the problem of COVID in the middle of our data collection period, I think we would believe that that big difference is a real difference and not just a COVID-related difference. But I agree, this is an issue that has undermined, I guess, the full comparability of our data sets, and we can't ignore it. Yeah.
Sumit, anything from your qualitative findings?
So I mean, COVID is important, but if you look at somebody with chronic breathlessness, COVID or long COVID does not manifest itself as chronic breathlessness of any kind. Yeah. If somebody's got an underlying condition, chronic breathlessness, we've chosen it because it's difficult to rely on diagnosis that people provide us. It could be chronic obstructive pulmonary disease of some kind, some other lung disease, it could even be congestive heart failure. As long as people have breathlessness severe enough to restrict their day-to-day lives, we were interested in what they were doing about it. Now, the people we've interviewed, they range from somebody who had a problem that began 6 months ago to all the way 25 years ago. So they have had that problem for a while. COVID happened to them like to you and me in between. Qualitatively, in Maharashtra, COVID did not come up as part of the conversation 6 months after the restrictions were lifted.
Perception, health-seeking behavior has changed a lot post-COVID. So people might be having some kind of breathlessness 4-5 years ago. They never took it seriously or they were not interested. But post-COVID, even if you have for 20 days, when you go on grassroots travel surveys, they might say we were having since say 3 months or 6 months. So they are making a point out of it. So that's being reflected in newer surveys, which actually we don't find in the earlier ones. That's the point I was trying to understand. Yeah. That has that point been taken into consideration or some?
No, we did not prepare for it, as Barbara was saying. And what I'm trying to point out is that in the qualitative in-depth discussions, this has not been invoked either.
Yeah. Thank you.
Yeah. Let's give a chance to the gentleman.
So the recent increase in spending.
If you could introduce.
Yeah, I'm Nafis, I'm from AMU, Aligarh Muslim University. Sure. So yeah, so I was looking at the recent funding, the increase, and in 21-22, health and wellness centers got 1,900 crores. More than 3 times the money was in PMJ. Now, health and wellness centers require more money, we know this. And it borrows from Professor Rama's point also, but this question is for Barbara McPeak, that this recent increase in spending, it's actually feeding into reverse pyramidization of our health system. So when you say that a minor increase or some kind of increase is actually helpful, isn't it also increasing this reverse pyramidization, the health provisioning architecture? So how do we know that funding is a necessary condition, but it's not sufficient because we are, the spending should have been more here, 3 times more is spending elsewhere, and then it is, it'll create a condition where the reverse pyramidization will increase to a very grand level. So maybe is it changing? I wanted your insights on that, yeah.
Okay, so I think what's come across from both discussants and from your point is that, well, as you say, it's a necessary condition. So we certainly want to recognise where the investment has taken place, and that's very helpful that there's a willingness to invest. Because I think if you went back 15, 20 years in India, there was this great scepticism about the value of investing and this great belief that the private sector would be the solution to health system problems as opposed to the further entrenching of some of the health system problems that I think we saw it was. So I think that's really important. But I think what comes across from all of your comments, that it's not sufficient in the sense that all public spending isn't of equal value, and I think everybody has said it's important to move on from the point that public spending is important to thinking about how to spend it best. And I think your point is a good one. We particularly think that the health and family welfare centres with Ayushman Bharat is the kind of spending that particularly picks up on responding to the problems that we're identifying here. PMJ less so, and we could talk more about that. But I think the main issue is that there are some very good public investments going on that we should applaud and encourage and perhaps really focus on that.
Any comments from anyone in the panel? Sajjan, no? Okay, well, perhaps you could ask your question.
Yes, hello, I am Ayurna Bhattacharjee. I am a faculty of economics at IMI and I primarily work on health. So amazing study, amazing findings. But what I was thinking is, you have specified 3 specific criteria and then looked at their health-seeking behavior. To me, it is also very important because we are getting motivated by the incidence of NCDs in the Indian context. So was there any particular reason why you looked at identification of the disease and then their health-seeking behavior, rather than looking at health-seeking behavior in the primordial stage as well? If I see health wellness centers nearby, I'll be more cautious. I'll probably be going in for more health screenings and so on to prevent NCDs. And the second thing is, why just the focus on these diseases, especially the 2 respiratory related diseases, which could partly be clubbed even under the communicable diseases. So there is some bit of an overlap there, rather than looking at diabetes or cardiovascular diseases, even though I know you are looking at an urban-rural split where there is a dominance of the urban areas. So it's more prevalent there. Was there any specific reason, or do you also have data on that which could probably be analyzed? Thank you.
Right, that's a very nice question. So the global burden of disease data that we have for India points to the significant burden of chronic obstructive pulmonary diseases. So chronic obstructive pulmonary diseases manifest as chronic breathlessness with acute episodes which require care. But not everybody with chronic obstructive pulmonary disease necessarily requires care all the time. But if you were to take the other example of diabetes, you should not have, but one can have diabetes and not take any medicines and not feel the need for care all their life, till that moment where they have a renal failure or something goes wrong with the eyesight or something like that. So, but the chronic obstructive pulmonary disease or chronic breathlessness is something else. An acute exacerbation of COPD, asthma, feels like you're just going to die. You desperately need care. So we were interested in what do people do when they feel that they need care, or they have a condition that is severe enough for them to determine for themselves that they need care. So this was a strategic choice. On the common chronic gynecological conditions, again data shows that the burden of menstrual problems in India is massive. We also know that it is underreported. We also know that women procrastinate, delay, postpone, normalize all of that. But we also know that women recognize that this is a problem that requires care. So we were interested in saying, okay, this is a different kind of a chronic condition. We need to understand how care seeking transpires there. We were not interested in the underlying diagnosis. It was not possible for us. So therefore, we have focused on what are symptoms and signs.
So perhaps just to add a little bit to that, I think we agonized for a long time over the conditions, but this question of should we have looked at health-seeking behaviour more generally and then homed in on conditions, that's what the available data will do. And so we know an awful lot about the generality of health-seeking behaviour. And one of the Well, there are two major problems with what's routinely available that we were trying to address. One is that you can't know what condition people have, and therefore start to understand the particular demands of non-communicable diseases on the system and the particular issues that's giving rise to. Because, obviously, if you think about, interviewing 1,000 people about the last time they used healthcare and trying to do anything sensible with what they can tell you about their symptoms, it's an impossible problem, really, of trying to categorize it at all. So the starting point definitely had to be the condition, and then we could have some populations that we knew what was up with them, and therefore with some kind of standardization. Although, of course, those conditions, there's a range of conditions within these bunches of descriptions. But that's what we were trying to do. And I mean, I absolutely take your point that prevention is better than cure. But the issue I think that we were more interested in was not what do you do about non-communicable diseases. That's for somebody else, PHFI or something. What we were interested in is, given India has this enormous problem of non-communicable diseases that, according to the most recent data, is still a growing problem. The most recent data aren't that recent that I was able to find anyway. But it's not a problem that India has under control, or that the preventive strategies are all showing signs of working. Then the health system responds or it doesn't, and the implications for household economies were at the centre of our thinking. So yes, I absolutely would not suggest that anybody's work on trying to help people prevent getting COPD is of any less value than what we've done. It's probably, as you might say, of more value, but that wasn't our question. Our question was, how should the health system be responding to the fact that India has this enormous problem and hasn't yet managed it so that it's not such a big issue for households.
Would the audience, let me ask if Rama or Rajan or Prabir want to have any thoughts on this? Any comments?
I think choosing a condition is also defined by, how you see it being amenable to the question that you're asking. But I would say that diabetes is a very interesting entry point to understanding the complexity, because there is, from whatever studies we have seen, and we have seen the evidence, people do recognize signs and symptoms, but the responsiveness of the public health system to be able to give you a diagnosis is actually very weak. And I think you may consider for your future work to really look at diabetes a bit more seriously.
The point well.
But that you're speaking from Kerala or from other parts? No. I'm looking at human behavior.
Yeah. But point well taken. Huh? We are in the midst of beginning a study where we're taking diabetes with symptoms, with complications, and trying to understand what havoc it wreaks on people's lives. So beginning that work. Patterns of resort.
Systems of medicine also, and there's back and forth. It's just very messy.
Yes. And we are the diabetes capital of the world. So.
Yes, please.
First of all, I'm Anuradha and I represent United States Agency for International Development, USAID. First of all, congratulations. Whatever I have heard is amazing. And I'm very sure you want that this report should also influence health system strengthening, as Dr. Sajjan also pointed to. So my first question to you would be, how do you see the cost that is incurred on the drugs? Is there a bifurcation in it telling you whether it went on the antibiotics or on simple drugs? Because purchasing antibiotics on the counter is not very beneficial for even a COPD patient, because you are increasing the AMR chances for a patient in long term. So if there's a bifurcation available in your study, that would be very, very helpful to understand that dynamics. I think the second would be, you raised a very pertinent point in terms of the index that Neeti is giving in terms of high performing state versus the low performing state, and where you say Orissa is coming out as one state where health seeking behaviors in terms of public trust is far more, even though it's a low performing state. What makes it a low performing vis-a-vis the communitization? Is it affecting the trust in the system? So the overall build of the Odisha systems, where communitization is stronger, as compared to Maharashtra and Punjab, where probably it may or may not be lower, and how does it built into the stronger or the weaker health system would be something of interest when we are working on the health systems. So if these points are already present in the study or can be explored with the current data, that would be really useful, for an organization like us. Thank you.
I think I can respond to the first one immediately. Perhaps you should actually. No, you should. Actually, no, you are the person.
I'll make one point just. In Odisha, what we have observed that around 40-45% people, even more than that, they have the Biju Kalyan Swasthya Yojana. So, and they access it. And the public providers are also in very good condition in few places as compared to other states. So that may be one of the reasons.
And Coach, what about the antibiotics question? We don't have the data, do we?
We don't have the data.
Maybe I can also add to that antibiotics question. So my reading is that going to people to ask about antibiotics is fighting the wind. You cannot get reliable answers. So in the villages I went to, and I've all those 20 villages we've talked about. So when somebody introduces the Dakt Sahab aaye hain, whatever and all of that, they will come out with these polythene bags full of all kinds of empty. They have many people, many understand, but a whole lot don't understand what they're being given. But they have all records in their own form, some with empty prescription, these strips, some with old prescriptions and so on. So we don't have that information in our data, but going and doing these population level surveys is not the mechanism to find out the bifurcation either. So, yeah. Ajay, you want to come in?
No, I've done. We should answer that question. Any other thoughts? Let's start with the gentleman at the back, and then after that, I'll come to you. The one in green, please. Please identify yourself.
Myself, Sujoy Pal from JNU. So my question is regarding a very generic issue, which is self-reported morbidity. So before utilization, before seeking treatment, the first thing which concerns is self-reported morbidity of the patient, and many sample survey actually admitted the limitation of self-reported morbidity. So you have done a sort of primary survey. So how you have just take the challenge of taking the self-reported morbidity? So.
I'll start, and I think my colleagues may well have some other points to make as well. But I think there are lots of different issues with self-reported morbidity, but one is this basic question that nearly all surveys use, which is, have you been sick in the last whatever period? And one thing that we know about that is that poor people have a much higher threshold for considering themselves sick than rich people do, for example. So it's not a great question. But that's one of the reasons why our starting point was people agreeing that they had somebody in the household with a very specific set of symptoms. So we didn't say, were you sick? We said, have you got anybody with these particular characteristics of breathing difficulties or these particular characteristics of gynecological complaints? We don't know that that's better, but at least it doesn't fall into the category of things that we know aren't good. And we think it's probably better, but it may well be that other people in the room understand some more pitfalls of those kinds of questions on a self-reported basis. But I think, to my mind, looking at it from a sort of more logical rather than empirical perspective, the more specific the question, the more specific the answer. And this is a much more specific question. But I don't know if others. No.
I think this captures it, and we made it fairly specific. For chronic breathlessness, we asked severe enough to disrupt your day-to-day life. And of course, we had a time period longer than 6 months to define the chronicity. We had qualifiers built in to specify what might that be. So walking for a particular distance, breathlessness at rest. So these are classic definitions within the chronic obstructive pulmonary disease space, which are used to qualify severity. So as Barbara says, we used various ways to say, okay, how can we overcome this self-reported wellness or illness aspect of the question?
I'm Pallavi from Health Systems Transformation Platform. Thank you for a very interesting study and some very good insights. I have a couple of questions, basically some more light if you could throw on these. Since, as we know, the pattern of investment in the last 4 or 5 years, and we're talking of Ayushman Bharat, which has 2 components, the health and wellness and the PMJY. And because the study looked at out-of-pocket expenditure and catastrophic health expenditure, I was wondering if there was any intersection with the PMJY that you found. This may not have been your main research question, but since you were looking at OOP and does it protect people, so did you see PMJY playing a role in protection? I know Prabir just mentioned about the Biju Swasth Kalyan Yojana, I think in Odisha, but elsewhere, and what are your thoughts on that? Did that have a role to play? And secondly, something about what you said, Barbara, about increasing catastrophic health expenditure, not necessarily meaning increased expenditure on drugs. If you could develop on that a little more as to what does that mean? Thank you.
Okay, thanks. Let me start with your first question, which is one of the things that I had to run over a bit quickly because I was running out of time, is that we do see some quite interesting regression results attached to health insurance, not necessarily PMJ, but do they have some kind of health insurance? And of course, there's PMJ, there's lots of state level initiatives, they all have different characteristics, so it's a rather vague thing, but again, I'm not sure how well people can describe exactly what health insurance they have and what it covers. I think there are a whole lot of issues around that as well. Now, the health insurance was typically a significant variable in explaining both whether people spent money on healthcare or not and how much they spent on healthcare, but it didn't have very consistent sign. And it has a consistent sign around whether or not they spend any money, and it increases the likelihood that they will. But not as much as some other variables, but it's there and it's significant in some categories. But it has an inconsistent sign when it comes to will they spend more or will they spend less. And I think that's not surprising. I was just reflecting on it, and an example that affects me at the moment is I've just given up my private health insurance in Australia because I'm spending half my life in the UK at the moment, so its value goes down for me, right? And my dentist tells me that I need a root canal. And I'm thinking that if I had the health insurance, the root canal might cost me maybe 2,000 Australian dollars. And if I don't, it might cost me 15,000 Australian dollars. Australian dentistry is expensive, right? So if I have the insurance, I might go for the root canal treatment and spend $2,000, but because I don't anymore, I probably won't. I'll just keep patching it up with a few $100s here and there. So actually, not having the health insurance is making me spend less. But you can also, the more logical one is that because you have the health insurance, you can afford things, right? So, sorry, I've just got that the wrong way around, haven't I? If I had the health insurance, I'd spend more. Because I don't have it, I'd spend less. And it's perhaps the more obvious relationship would be, I'll have the root canal anyway, but I'll spend less because I've got the insurance. But it's not as straightforward as that, right? So we do see both signs on insurance generally, but it's not about PMJ specifically. And
we can't say it's about.
No, we can't say it's about PMJ.
There was a second question.
Yes, I've forgotten now. Sorry, can you repeat it? Right, so what those graphs showed, and apologies again for having to rush through those later slides, is that the higher the rate of chronic health, of catastrophic health expenditure, the higher threshold for it, the lower was medicines in the total expenditure. So if we look at all out-of-pocket expenditure, as I did on another table, it's about 50% is medicines. But when you look at how much is medicines for people who are spending 40% or more of their total household expenditure, it's more like 20. So the more catastrophic the expenditure, the less it's medicines. So perhaps the policy lesson from that is that if we want to reduce the most extreme catastrophic health expenditures, just focusing on medicines isn't going to do it. It's either hospital fees or provider fees. Yeah.
So, you got a question?
Well, surgery wasn't
And
it?
that will be the second last question. After there will be one last question.
If anybody's got a question, let them ask.
No, you are the one now.
Yeah, no, I would like to sound a little bit of caution on this study. I mean, great study. Sumit, your first time also I was there, and I'm glad it just got completed now. But I would recommend don't push it too much. You know, because remember, your sample is kind of self-selected. It's for a certain condition, chosen by people who recognize they are sick, and therefore focus on a part of the health system alone, on the treatment part. So, extending that conclusion to a judgment regarding the health of the system, you will admit you will agree is not too much to push for on the policy dimension. And again on PMJY, my second point is comparison between states are extremely dicey. You know, states, a simple measure, you're looking at people who access treatment. NSS asked a question about the propensity to access treatment, and you know the difference between the one at the one end and what is at the other end, the tendency of people to seek treatment. That itself will influence the behaviors that you have seen. And frankly, this fact that since the slack in public expenditure is so high, from maybe you should expect about 9.5% of your GDP to spend on health, we are spending just about 1.5 on the public sector. Any increase in public sector the slack is so much that any increase will show up like that. But the interesting thing would be invest where. That would be a very, very interesting thing to look at. And the point you made about the navigational guidance at the first point of contact, which makes it, in any advanced health system, it will not be possible for a person to go and shop for treatment, which you can do in India and which we are very proud of, actually. Now, so redesigning the system, it will be good to, that's a very good finding that I think we should be looking at. And I think the impact of PMJY is overrated, because if you look at the amount of consumption, it's high only in very few states. And I think we are pushing too much onto PMJY. I don't think it is. It's making anywhere near that in many of the states that we are looking at. So maybe there is a scope for a further study to understand these differences between states. Why this is happening, and just based on this, I would be cautious about putting it too much. And as Radha mentioned about the policy recommendations from this, it'll be interesting to see what comes out. But please bear this caution in mind.
So Rajiv, I take it as a comment, not so much as a question.
It's a comment, yeah.
Okay. Any last questions? If not, we can have tea, but that's one last question I'll allow for.
Tushar Mokashi from Access Health International. Hi. So, picking up from the first point that Barbara said about increasing 100%, 100 rupees, I'm assuming it's per capita, right? So that would be around 5% of what we are currently spending, the government spending currently in India. So 5% is quite huge in that sense. So that would mean that. But anyways, that's one part of what I want to ask. That's point number one. Point number two is about the spending on primary care. Government spends almost 50 to 53% of its health expenditure on primary care. So how much more on primary care? It says that the policy says 33%, 66%, 1/3 of the total expenditure should be on primary care. If we do this 100%, 100 rupees more, probably we'll cross that target. So 100 rupees sounds less, but I mean, in the scale of it, it is quite huge. My question is, the third point that I want to make is, our spending in the public health system, the way we are looking at it, say the NCD part, there's a national program on it, there's a lot of money invested, but this is one of the least spending, underutilized, highest underutilized. Yes, I'm sorry for that. So I was just coming back to the point that Rajiv sir said, having the problem of low absorptive capacity. So given all this, what do you think is how do you like spend that money on what? And maybe from this experience of this study, do you have any sort of insights on what should be the spending on? So that's my question. Sorry, it was quite long.
No, that's fine. I think that's an interesting point. And I think what you're saying is that at the moment, the average per capita expenditure is about 2,000 rupees. Is that correct? And I think that, so you might say 100 is a lot. On the other hand, if you look at India's health expenditure compared to its neighbors and countries of similar income, you would be talking about doubling or even tripling India's expenditure. So on that, from that picture, 100 is not a lot. So I guess it depends on your perspective. But also, I don't think there's a country in the world that allocates enough to primary care out of its total health expenditure. I think it's a well understood problem from the highest income countries to the lowest income countries that hospital care sucks expenditure and primary care struggles to get its share everywhere. And there are political reasons, there are kind of health-seeking behavior reasons, there are all sorts of reasons why that is. So, I mean, I would agree that India doesn't have the right distribution between primary care, secondary and tertiary care, but nobody does. And I don't think India can solve that, you know, on its own. But clearly, to the extent that you can prioritize primary care over other uses for expenditure, that definitely should be something you can do. But it is an uphill battle everywhere.
Let me just say thank you to the panel. This is a big hand, I think.
And the discussants.
Yes.
And we are just to conclude the session. So, yeah, which has been a very interesting session. I'm sure everybody enjoyed the session very much, and it was a wonderful afternoon. But tea is tea. I don't want you all to be craving for tea anymore. So I'll just thank all the presenters, Professor Mahal, Professor Sumit Kane, Mr. Ghosh, Barbara, and of course the esteemed discussants, Professor Baru and Mr. Sajjan Singh Yadav. And thank you all participants for being here. Tea and great refreshments are waiting outside. Welcome you all to please join us for the tea. Thank you all. Thank you. Thank you very much.
Poonam, the director, is very, very keen that people have the tea.